thank Pratap sir and the organizers for having given this opportunity. Well, I'll start with the case history of a 70-year-old gentleman. Post-angioplasty to the circumflex, the stent could not be properly deployed at that point of time. He presented to a nearby hospital. The arrest angina, troponin was positive, so was taken up for angiographic evaluation. You could see that the circumflex has got the stent and there is significant restenosis over there. And you could also see that the stent is under-expanded in the circumflex territory. In the second image, you could see that the OM1 has got a very critical stenosis. And you could see in the stent boost that the stent in the mid portion, it's not properly expanded. So they tried to open up the vessel with multiple non-compliant balloons. They wired the OM1, OM2, multiple balloon dilatation. It was not possible to open it up, so was referred to us for a possible stent ablation. These were the images taken in our cath lab. The first one, you could see that the stent is under-expanded in the mid portion. Second image, you could see that the OM1 and OM2 is flowing well, and there is a tight stenosis in the stented segment with an under-expansion. Well, we started off with a 1.25 millimeter bar at 160,000 RPM. We were gentle with the lesion initially. You could see that we were able to make some progress into that particular under-deployed stent. It wouldn't move distally, so we had to increase the RPM to 180,000 and even 200,000 RPM. Well, even at 200,000 RPM, we were not able to get across the lesion. Now, how does stent ablation work? There are three mechanisms. One, it ablates, cuts or pulverizes the stent struts. Secondly, it ablates the calcium that protrudes through the struts. And once the struts are ablated, then the superficial calcium can be ablated. Thirdly, most importantly, heat generated leads to thermal injury that liquefies the stent as well as calcium, which makes it more supple so that you will be able to dilate with a high pressure balloon. So nearly 12 runs of 15 seconds each, 160,000, 180 and 200,000 RPM. Not able to get across the lesion. Patient developed angina, slow flow. So we had to remove the burr. You could see that the flow inside the vessel is not so good. So at this point of time, we thought that we have done enough of burring. Even the thermal injury, probably we'll be able to dilate with a high pressure balloon. We tried to go in with an OPN balloon. The OPN balloon wouldn't track into that. However, we tried to get with a non-compliant balloon. Non-compliant balloon would track it, but then we were not able to open it. Now we switched over to the next New York burr, the second new burr. That's a 1.5 millimeter burr. Started off with 160,000 RPM, increased to 180,000 RPM, and again even up to 200,000 RPM. Some point of time, I started becoming impatient and try. You could see in the first image that I was trying to do the burring. You could see the guide catheter is backing out, which should not be done at any point of time doing rotablation. Try to resist the idea of pushing it through and kept on burring it. Again, another 10 runs. So we used two burrs, 1.5, 1.25. We were not able to get across. We again had started seeing slow flow inside that. So we again thought that probably the thermal injury would help. Again, we started trying with the non-compliant balloon and the OPN balloons. The non-compliant balloon would go into the lesion. However, we are not able to open it. And the OPN balloons, it would partially go into the lesion. It wouldn't really get into the narrowest part of the vessel. So at this point of time, we couldn't do anything much. It was almost 1.5 to 2 hours at this point of time. Then again, we moved on to a third burr. This was a 1.5 millimeter burr. The third one, the new burr. And at this point of time, you could see that we were able to get across. Then you could see that we were doing the polishing run and finally went ahead with bifurcation stent implantation, opened up well, and we could achieve a good result. Well, is stent ablation dangerous? Well, you could have two complications. Perforations are very rare. You could have a stent a stuck burr in approximately 10% of situations if you're very aggressive with pecking movement, and if you're very aggressive with the ablation, you're likely to have a stuck burr, and you could also have slow flow with aggressive burring. And what about particle size that's produced during the stent ablation? It's a 2009 Japanese article that says that 90% of particles generated is 5 microns. It flows through the microcirculation taken away by the reticuloendothelial system. However, a porcine model 2012 article, 80% of particles are less than 5 microns. However, 95% particles less than 15 microns in size. This is a very interesting article, a Japanese article, a case study. Approximately under expanded stent, 1.75 millimeter rotablation, stent ablation was done, stented, and you could see in the second image that the distal portion of the stent has been totally ablated off. And what is interesting was that they assessed the index of microvascular resistance also. Pre-procedure microvascular resistance was 19, post-procedure it was 31. It increased transiently, and they brought the patient back after 1 month and they found out that the microvascular resistance has come down. So whatever said and done, whatever small particles that go down, that can at least lead on to microvascular obstruction, and that can lead on to trouble. Well, what should be the ideal technique of doing a stent ablation? Most important thing, be gentle with the under deployed stent. Try to advance the rota wire over a microcatheter, because you have an under expanded stent. If you try to meddle with the floppy wire, you might damage the rota wire. So it's good to have a workhorse wire used, then a microcatheter, and then exchange with the rota floppy. Start with a smaller burr, 1.25 or 1.5. Step up the burr size in most of the situation, not exceeding 0.6. Burr to artery ratio, lower speeds preferable, 160,000 rpm, shorter runs 15 seconds. Give a better breathing space, at least once, wait for 1 minute before you go for the next run. Avoid more than 5,000 drop in rpm, or never try to push the burr through. And if at all you have to wait, or you have to continue for more than 10 runs, hope that you have eroded the burr has been eroded, the burr has become bald, and switch over to a new burr. Now, why would you want to switch over to a new burr? This is an electromicroscopic study. You could see that the rose arrow, it points towards the diamond chips, and you can see the green arrows that's looking at diamond pits. What has happened is, when you do a stent ablation, these diamond chips, that they get eroded away. So maximum beating happens with the first burr. So with the first burr, if you're not able to cross the lesion after 10 times of 10 runs, probably you need to switch over to a second burr. This is another patient who had a dextrocardia, proximally ostial and lady stent implantation. You could see in the second image that that particular area, the stent is totally under deployed, which was done long ago, and you could also see that there is significant amount of calcification. Went through the femoral approach. That's the first image. You can see that the ostial LED is totally stenosed, and an under deployed stent or under expanded stent in the proximal left-handed descending artery. We inverted the images. In the second image, you can clearly see the stent over there, which is totally under deployed stent in the proximal left-handed descending artery. Again, the same procedure. 7 French guide catheter, 1.25 millimeter burr, 1.5 millimeter burr, 180,000 rpm, 200,000 rpm, and finally we were able to get across nearly burr time of almost 4 minutes. Once we were done with that, we did a balloon dilatation. That was in cutting balloon, and following that, you could see in the second IOS run, you could see that the ostial LED is almost a 3.5 millimeter vessel, and the stent seems to be so much under deployed. Mind you, it was after the rotablation as well as balloon dilatation. You can also see some calcification over there. Finally, multiple balloon dilatations, we were able to stent that, post dilatations, and that was the final result. You could see that the ostial LED is well expanded. These are the pre and post procedure images of this particular same patient. Well, what does the data say regarding stent ablation? An article published in 2019 says that success rates are quite good, nearly 100%. However, the MACE at the end of 1 year is approximately 40%. This was an article published in Euro Intervention 2016. 12 patients stent ablation. The overall MACE at 6 months was almost 50%, and the mortality was almost 25%. And the burr entrapment was on nearly 0% in this particular study. What is very interesting down there is, every time you want to be very gentle while doing stent ablation, and you always tend to say that more than 5,000 deceleration should be avoided, but then they made out that 100% of patients, they had deceleration more than 5,000, which means that when you want to do a stent ablation, you have to be really hard onto the lesion. So in closing, dear friends, technical success of stent ablation is extremely high. Be cautious about with respect to stuck burr and slow flow. Despite good initial success, the long-term MACE seems to be plentiful. So the most important point in preventing to avoiding stent ablation would be preparing the lesion. When every time you see a lesion, prepare the lesion well, deploy the stent well, so that you do not have an under expansion, do not have to go in for stent ablation, and that's how you could avoid long-term problems with the patient. Thank you so much for your patience.